This afternoon, welcome to this special episode of the show that we bring to you right now, because in most cases we know that from 1 to 2 you could be used to the lunchtime request show hosted by Sugar Arafat, but then due to the political season and a few other activities, as we know this season, it's a beehive of activities going on in the country, and probably a few of these changes are actually expected at such a time. My name is John Jimmy Musimbi, and I welcome you to the show. This time round, we shall be discussing health at this point in time, and we shall be digesting issues to do with malaria as we move on. And of course, in a bit, I'll be introducing to you my guest that's with me in studio, and we shall be keeping the conversation moving. Now, before we proceed any further, we all understand that malaria is a life-threatening disease which is caused by parasites that are transmitted to people through the bites of infected female Anopheles mosquitoes, but it's however preventable and curable. In 2019, there were an estimated 229 million cases of malaria around the world, and an estimation of about 400,000 and 9,000 deaths, which accounted to about 67% of these being in children aged under 5 years, which makes about 274,000 children actually. Now, Uganda has the third highest global burden of malaria cases, taking about 5% of the global burden, and the 7th highest level of deaths at about 3%. It also has the highest proportion of malaria cases in East Africa, and actually not only East but even Southern Africa, which is about 23.7%. Between 2017 and 2018, actually, the country made significant strides and was able to reduce the case numbers by about 1.5 million, which accounts for about 11%. This may have been as a result of successful rapid public health response, where there was a wide distribution of mosquito nets, and of course we give thanks to the Ministry of Health and government for that. Now today we are talking to Dr. Daniel, an epidemiologist with the Ministry of Health, and we shall be discussing more of these issues with him. I would love Dr. Daniel to say hello to the Record TV viewers this afternoon.
Good afternoon, all our viewers on Record TV. My name is Daniel Chabainze. I'm an epidemiologist from the Ministry of Health in the Malaria Control Division, and thank you for tuning in to listen to such a very important topic we are having today.
Well,
thank you, Jimmy, for hosting me.
And I'm also glad for this rare opportunity, I would call it, to host a well-expertised gentleman like you, that we shall be discussing more with issues to do with malaria. How is Ministry of Health doing? How are things going on there?
I think we're doing very well. We are battling a number of things going on in the country, but you know, it's continuation of health services as usual, despite the fact that we are still grappling with COVID in the country. And I think the ministry is also having to do all the other service provision, ambulance services, curative services, prevention, immunization, and all the other pillars, you know, of communicable disease control, and also continuing to give guidance and policy direction for the general health facilities.
Well, that's good. We've been, as I was introducing the show, we were discussing issues to do with some of the figures I was giving here and the percentages about Ugandan stand on the global scale and probably East African scale, which is worrying. So I would love you to clarify, are those figures correct the way I read them, or you feel probably some of these reports have exaggerated them?
No, you know, the world has been moving towards malaria elimination. In the last 20 years, the global malaria incidence in the whole world has been coming down, especially in sub-Saharan Africa. But despite that so much success, in the last 2 years actually, we've seen a leveling off of the trajectory, which we had expected that by the global malaria strategic plan was that by 2030, malaria would have been eliminated in many countries. Uganda has been also doing very well in reducing the number of malaria cases, but in the last 1 year, as recently reported, our cases have stagnated. We still see over 6,000 malaria deaths in Uganda, yet we had come significantly lower, especially in 2018, which has translated in globally a 30% increase in the number of cases. Secondly, we've also seen the number of malaria deaths also stalling. We've not made as much progress, especially in the last year, but there are many factors which we can discuss which have translated to this. Generally, the country has been doing well, especially in the last 10 years, in trying to grapple with malaria. We used to comment that a child dies every minute of malaria. That means a child dies of malaria in Uganda, but now we are talking about losing about 16 people per day due to malaria. The other year,
which was some progress.
Which was some progress, but now we are saying it's stalling because we had actually reached 14 cases per day of dying of malaria. That means the number has slightly gone up by a factor of 2, which in terms of number of people may sound few, but when you compare to the whole population, that's a very big number. You're looking at saying 5,000 to 6,000 people dying of malaria in a year.
So I would love to understand what are some of the contributing factors to, you see in your explanations you point out a very worrying situation back then, and then there seems to be some progress ahead, and then a backlash. What is the reason for this?
Okay, we know that 10 years ago, we used to use medicines like chloroquine and Fancida. There was a change in policy. We discovered that those drugs were no longer working as effectively as we had expected. So now the country moved to using ACTs, artemisinin-based combination therapies, and these included the common drug we used as Coartem or Lumatem, and these combinations were spread out and they are now widely available. That helped in improving the number of cases that were being treated. When a child gets malaria or an adult and you give them treatment, so you are cutting off the probability that that person will be bitten by a mosquito and the parasites moved from one child to the next person. So that means good and effective treatment in time helps prevent the burden and reduces the burden. So accurate and proper treatment. The government also rolled out using new methods of diagnosing malaria, because previously everybody who got a fever would go to a health facility and we use a microscope to tell that you have malaria or not. But that skill was not so widespread and it was putting a strain on the health facilities. So now the ministry started using rapid diagnostic tests, and whoever walks into the health facility or goes to a drug shop or goes anywhere, they're able to be tested. So we're now able to tell who are people who truly have malaria based on the blood test. So combining good diagnostics and good treatment helped to reduce the burden. Now we moved from doing care for those who came into the health facility and we moved towards prevention. And we can prevent malaria in many ways, but one of the key ways the government came in was to distribute mosquito nets to the whole population. That cuts the mosquito-human-person contact, and that barrier prevents the mosquitoes which come in looking for a meal to transmit malaria from one person to another. Those are some of the key areas where we have seen interventions helping us reduce the burden of malaria. And many people in the community could tell that the number of people who are going down with malaria or fever is coming down. The other way which government also and partners invested in reducing the number of malaria cases was to control the vector, which is the mosquitoes, by applying a chemical on the walls of the houses. So we call that indoor residual spraying. They spray onto the wall a residual chemical which remains and kills every mosquito which comes and sits into the house seeking a meal. So in that way, we were able to reduce malaria burden, especially in northern parts of Uganda where that was widely used.
Yeah, you talked about probably many centers being able to test, but I realized that most of these tests actually do not tell the level. There are tests where a hospital can make until you have malaria plus malaria, but then there are those you go, they will only use probably a strip where blood will drop. How does one tell the level of malaria? Doesn't that worry somebody out there that probably they could give a simple dose for a serious malaria fever in you? Doesn't that hold back the fight against malaria?
So I will just explain the way we look at the parasites. When we previously used the microscope, they draw some blood, and when they put that blood applied on a small slide, many people would be able to see that. Then somebody stains it and is able to visualize the parasites themselves and is able to count how many he sees in his eye views based on the number of red blood cells. So we call that a parasite density. That is what you are calling how severe, how many parasites somebody is infected. You know, malaria, parasites multiply. So the number of parasites you have at a time is a result of you having either come late to the facility, or when you got the disease, your immunity was so low that the parasite multiplied quickly. But when they introduced what you call, when you see on a strip for malaria, that one is picking the byproduct of the parasites. Not to go into the detail, but it's able to tell us whether you have had a malaria parasite in your blood or not. Not necessarily counting how many parasites. The treatment is going to be the same. When we find out that you have parasites or you have fever and the strip is showing positive, then we know you need a malaria treatment dose. The dose we give you is not dependent on how many parasites we counted, but it is going to be dependent on what other symptoms you had. So when you come in with a fever, you give us a history of a body temperature, you give us a history of a headache, weakness for children not able to face, and we can see that we can examine you, then we give you oral treatment, anti-malarials. When you see that you have other signs and symptoms of complicated malaria, which you called severe, even if we have not counted the parasites, we will put you on treatment which will help us to immediately make sure that the parasites are rapidly dealt with. So we give you intravenous in your vein, either through a drip or through the line. The most recent drugs we are using is now artesunate. So we give you IV artesunate, 3 doses for the first 24 hours to make sure that we reduce the parasites. When you are able to drink and the parasite and you are actually revived better, then we switch back to the oral treatment.
That's a good explanation, and I believe the next time I move in and my blood is taken on a strip, I'll not have worry about the treatment I'm to get. But then I've realized there's a very big difference when you weigh between the side of the urban areas and the side of the village areas. I do not know whether the Ministry of Health has actually realized this, that malaria prevalence in rural areas is actually higher than the prevalence in urban areas. I do not know what plans does the Ministry of Health have to fight, and why is it so anyway?
Okay, I'll just expound a little on what you talked, the malaria parasites. And we know that the mosquitoes which spread the disease actually concentrate differently based on the environment and weather. Let me take you back to 2019. We did what we call the malaria indicator survey to measure the whole country to see how widespread the malaria disease is. The national general average is 9%. And when I say the prevalence of malaria in Uganda is 9%, meaning for every 10 people you see, one person has a malaria parasite, or when you test them, you'll find that they have malaria. For 100 people, 9 people, generally in Uganda, would have malaria parasites. But that was back then. And now we've just seen the new results showing that the trend has gone. So the prevalence is different when you come to urban setting. You know, in the cities, people live more together, and they are living in houses which, whether the drainage is not good, will have higher probability. But the reverse is actually true, that many people in the cities suffer less malaria than in the rural because they have better housing. You know, the mosquitoes will have to come into the house for them to be able to bite you. In the villages and communities, some of the houses have open eaves. You know, some people are living in thatched houses. Others are living in houses, but the way they build them, they leave an open area where mosquitoes come in. So those houses will benefit from making sure we close those parts of the eaves or ventilation to prevent mosquitoes from coming. And then the way the houses are spread out. For instance, above Lake Choga, the Choga area, this is Amolata, Dokolo, Teso region, the place and the plains are very flat. When it rains, there's a lot of flooding and retained water. So these areas have significantly higher malaria cases. But just to let you know how malaria is the current burden is in Uganda, we have places which have very low prevalence. Places like Chigezi area, Chisoro, Kabale, and those areas have very low malaria. South Buganda and Kole have less than 5% prevalence. Places like Hoima and Bunyoro area have low malaria. But when you go to West Nile is the second highest prevalence of burden of malaria in Uganda, up to almost 24%. For every 10 people in West Nile, 3 people will have parasites. When you go to Karamoja, the same story. The whole of Karamoja area has a very high burden of malaria because of their lifestyle and the way they build their houses, and the mosquito are able to breed and stay, so they need to be given more attention. Then the south of Lake Choga, the highest burden is around Lake Choga area, just below, that is the Busoga Belt area. The rest of the country has relatively made progress in terms of malaria.
You highlight these areas and say they require a lot of attention, but then I understand this has almost been the trend over the years in these same areas you're talking about. When you talk of attention, it's ambiguous. What attention? Attention in terms of literacy about what needs to be done, because you highlight the poor housing in there that is contributing to this. But do these people know that probably they do not have to live near stagnant water, because the housing might be poor, but probably there are other factors that could contribute to this. Where is the problem? What attention do you think the ministry needs to give these people, and how far has it moved towards that journey?
Okay. In the last 10 years, we had a malaria strategic reduction strategy, Uganda Malaria Reduction Strategic Plan, which tackled giving attention for malaria in a uniform way. You see, when we give mosquito nets, we give every area, regardless of what the burden had been in the area. So the attention is that for every Ugandan to be given the attention and prevention. We also know that these places, their economical activities are varied and different. So when you see the economical map, you would see that these places still have challenges in collecting household incomes and revenues to be able to give themselves better attention or better. But I'm saying that as the disease burden comes down in the whole country, it is coming down relative to its baseline or benchmark. When you're moving from 40, like northern Uganda, Acholi and Lango region, where malaria prevalence was up to 42%, it has now come down to less than 15%, meaning they are reducing malaria at a faster rate compared to Kampala and Wakiso, where it has always been less than 1%. And the more efforts we put in it still remain around less than 1% or close to 1%, meaning we are going to shift attention and put more resources. When we say attention, we mean more resources in terms of what are we going to do, more resources in terms of education, more resources in terms of behavior change communication.
Well, Dr. Daniel from the Ministry of Health, they are trying to explain to us to understand better some of these things because, you know, when you mention things and talk of attention, somebody would wonder what kind of attention do these people need, but then he highlights issues to do with education of these people to understand more on how they can prevent and probably how this is spread, and this can enable them to understand how best to prevent if they know how it is caused. Probably talks about the ministry putting in more resources towards the fight in these areas. My name is John Jimmy Musimbi, and the show takes a very short commercial break. We'll return shortly.
Hello ladies and gentlemen, eno ye 97.7 Record FM tusabula hits all day. Wakati mutima gwa Kampala wave the best shows nga tutandika ne UG breakfast show akawuwo okuva ku 12 mpaka sawonyezo okumacha the hit club omubezi sawa nnyo mpaka mwendezi obutundu the big evening ababa sawa mwenda mpaka emwe yakawungeze the hot 7 at 7 countdown mwetubulira ennyimba esinga okuja the hottest and the biggest songs weno ku 97.7 ate the love at heart omukwano mu mbewo etandika sawa 2 mpaka 7 ogw'ekiro late night kusoma obuwomi wa radio esengekeddwa 97.7 Record FM tusabula hits all day.
Hello, how are you? Tell me, how do you do?
We're here to show some appreciation for the things you do.
Thank you for today, and thank you for tomorrow. Thank you for every time and everywhere you go. We love you so, and we enjoy life with you. We are happy to know that we will go with you. That's why we say thank you,
Thank you for choosing MTN. Use MTN Mobile Money, bundles or other services to get Thank You points. The more you use, the more Thank You points you get. We look forward to many more years together. Thank you.
Tonight,
kale ku luno neetegese bulungi n'empulira ddala nga sigenda kuwoggana naye oba kinsimattuse kitya
naye nga wali onoonyezaako ku solution ewalalawo
asi nnyo kuba abakazi banzirukako ate ne nti okuswala ensalawo obudde mbumaliye mu bizinesi.
Namalo nali nakusuubiza okugenda okwetondera mukadde byebigere bino.
kale sebo tuuka bulungi.
Kale naama
kale abafumbirwa balina ennaku kati nennaabiri ali eri agamba nga bw'alina omusajja.
kakati maama luli nakuleetera nsawo ya sukaali na munyu naye kati kankuleetera embuzi owuute mu supu.
ate ono yawanvuwanga kalitunsi.
Maama
omwana mulenzi ekigere kiwanvu.
Mama
sapatu gy'ayambadde mpanvu nga kidyeri. Ndowooza nga togyayambala nga zinga mmeeri.
Kituufu omusajja yankuba.
Nga kkubira ki?
Mbu mwesibako ate nga tanjagala.
Naye ng'ekituufu takwagala gwa mwesibako.
Kituufu.
Yandi kunyiga obulenge yandiko.
Welcome back from that short commercial break. My name is John Jimmy Musimbi, and in studio this afternoon I'm joined by Dr. Daniel from the Ministry of Health, and we are discussing malaria because it's one of the key challenges that has persisted in Uganda for quite a very long time. It hasn't just persisted, but it has claimed many lives of many people that have succumbed to the disease. And that is why, as Record TV, we see it necessary to bring up to speed many of these issues and ensure that you get the education about malaria to understand its spread, its prevention, how can one control it, and probably how can it be treated. Now, Doctor, understand that despite the many efforts that the Ministry of Health is making towards fighting malaria, it is an on and off disease. You might find that somebody has suffered malaria in January, and then by June or July or December is suffering the same. Why is this so? Is it due to low immunity? Is it poor diagnosis in some hospitals? And is there hope anyway for a complete eradication of malaria in Uganda, despite you talking about 2030, which I see is a very short time from now, and the prevalence is still high?
And thank you very much, Jimmy. Just to let our viewers know that it is possible to suffer many bouts of malaria. Some 10 years ago, we were doing a follow-up on children around Mulago, and we found that one child got 9 episodes of malaria in a year. Those are so many. That means every month you are treating the same disease from that same child, meaning the environment where we are living, the disease is prevalent and is still available. And the people around us can still infect us. You know, malaria, the funny thing is it lives in somebody and is transmitted through a mosquito to another person. So it's a disease which we know if it's in the community, it's going to do to be around. And then we know that it comes in seasons. Because the process includes a vector, is something which transmits. It includes an intermediate vehicle. The vehicle of malaria from me to you is the mosquito. So we know that in Uganda we have 2 major rainy seasons. So once the rainy season starts, there is increase of water, and so the mosquitoes have where to breed. Mosquitoes need water to multiply. So once they multiply during these rainy seasons, the spread of malaria and the number of people infected with malaria increases. That's why you see that many people say, oh, during the rainy seasons, we see a lot of cases of malaria. After that, they calm down. Then also, so in February to June or May, we have a high number of malaria cases. Secondly, also September, October, November. Now the seasons are now becoming longer. We are seeing rain almost throughout the whole year. So that means there is a level of malaria breeding. The mosquitoes are multiplying, and there are many. And I know that even in your houses, you'll be able to see that there's a change in the number of mosquitoes you can detect coming into the houses in the evenings. So one thing is that the conditions and the weather in Uganda is favorable for the mosquito. Secondly, the diagnosis would have been good, but some people take so long to go for treatment. Thirdly, the young children don't have immunity, but the older people who have immunity can have asymptomatic malaria. Now that word is now very common, like we are having COVID. We have people who have COVID and they have no symptoms. They are still moving the way they are moving. So even in malaria, there are some people who have the parasites which cause the malaria in their blood, but they are okay. So when the mosquitoes bite these people, then the mosquitoes are the disease is transmitted to those vulnerable groups. The most vulnerable, as we saw that 2/3 of the people who died of malaria last year were children under 5 years. So children under 5 years have not yet developed the immunity to fight off the disease, and when it comes, it really finds them with low ability to fight because of their status. Also, pregnant women are part of the vulnerable group. When pregnant women get malaria, it gives them it is more severe. That means their immunity is low. They are likely to lose their pregnancy, to have a miscarriage, or if the malaria hides somewhere in the uterus or in the placenta, they are ending up giving birth to children who have low birth weight. And these children don't survive long when they are born either premature or low weight. So the prevalence and the dynamics of malaria happening in certain areas and is not only because of poor diagnosis, but also the seasons also have a factor to play.
Well, don't you think you as the Minister of Health, you've actually diverted most of the attention and efforts to the mosquito net campaign and forgotten about one of the issues disturbing society, like self-medication? How dangerous is it, and what is the ministry doing about this? Because I was interested in knowing some of the reasons why probably malaria has persisted on and off. But we understand that somebody could actually take wrong medication when he's treating something. For example, one of my aunties in Manafa last week went into coma, and the medical assistant says, in her explanation to him, was that whenever I could fall sick, I could take probably 2 Coartem and feel a bit fine. I go back home. Little did she know the malaria was actually piling up. So by the time it came all at once, I think the parasites had accumulated. She almost went into coma. Things were not fine. So don't you think that the efforts you've so much put on mosquito net distribution have failed you as a ministry at some level, whereby there is a campaign you've left behind and it's claiming lives and retarding actually the campaign to eradicate malaria?
I think I need to clarify about the campaigns. As you hear them, they are mosquito distribution campaigns. They are one-offs. So we distribute mosquito nets once in every 3 years, and we call that universal coverage campaign for early line, long-lasting insect nets. And our theme this time is under the net. It's not good enough to get the net, but you need to fold it out, use it properly, and sleep under it consistently every night. So it's not only receiving, we may be giving out mosquito nets, but the new message is, please, as you receive your net, use it and sleep under it. We have not diverted, because I've said every 3 years, but our biggest expenditure in Ministry of Health in terms of malaria control is actually not mosquito net distribution. We import and distribute over 30 million doses of anti-malarials in this country every year. So as you'll see, the national medical stores and all other JMS will all import drugs, and people will purchase them, and also the government will give the medications through many channels. One is through the health facilities. In the communities you go, as you've said, in Manafa, your auntie could have gone to a health facility in Coma, and then they gave him the treatment. Secondly, we have what we call the village health teams, drug distributors, or the VHTs. These ones are given medicines so that they are able to treat the children under 5, because it is important for the children to get treatment within the first 24-48 hours after falling sick. But they may come back in the evening from digging, and the mother realizes that the child now has a fever and cannot go to the health facility because of distance. These ones can quickly move to the VHT. The VHT will be able to say, what are the symptoms? Let me test you. Or even if I can't test you now, here is the start dose. So when we treat you early with the appropriate and quality controlled drugs, then we are able to treat the parasites. They will not multiply, and the disease will not become complicated, or what we call severe disease. So that's one of the things. The government, so giving mosquito nets is one, but we give accurate treatment, accurate and prompt treatment through the health facilities and through the community. Secondly, we also give mosquito nets routinely. When pregnant women go to the health facilities, they are given a mosquito net. So we do have those what we call the continuous channels, where we give nets so that the mother who is pregnant protects herself from getting malaria through the 9 months. There are other channels. We also do school programs. We treat and test people in schools. Now that the schools are closed, that channel is not being able. But there are also other services we give. You see, not every fever is malaria. We can test you when you have a fever, and we find that actually it's not malaria. That means we need to find how to treat you. So those are the other treatments people get. There's so many things which can give you symptoms of a fever. And currently, we would love people to be tested because they will not end up treating every fever as malaria. You know that there's so many other causes of fever, typhoid, tiredness, COVID. All those things can come up with fevers.
You highlight about, for example, pregnant women and I've seen many numbers of pregnant women in these government hospitals, and the nets are actually not provided as you talk. I do not know, and that of course justifies why probably the fight against malaria many steps ahead. Because you could sit in your boardrooms at the ministry and make very good interventions towards the fight, and they are not implemented because escorted people until they give birth, and many of these things they actually tell them to buy. Okay. And if somebody does not afford, that means that probably they are at a high risk. So what is the ministry? Do you just sit and talk about these issues, or you actually follow up to ensure that what you're talking here on TV is implemented?
We do have what we call a supervision strategy, and we also have what we call area management visits.
But how effective are they?
And you've seen, those of you on TV, how the top leadership goes and interacts with the people in the different regions, in the different hospitals, to see how services are given. But I want to go back because you mentioned the pregnant women. When people get pregnant, our advice and policy means that a mother must get anti-malarial drugs. That means what? We need to prevent malaria by giving them treatment as soon as they are 3 months pregnant. You are supposed to take a dose of Fancida 3 tablets once every 30 days until you deliver, because we must make sure that you do not get malaria until you deliver. So because your immunity is low, and when you get malaria, it affects both the mother, the blood will go down, and we need you to be feeding your child inside, and then the child will also not grow. So we want to prevent malaria in the mother, but we also want to prevent malaria in the unborn child. So those are supposed to get Fancida at what we call the antenatal care clinics. That's why you see them at many health facilities. Every month we need the pregnant mother to be coming, to be weighed, to be checked, to see that the child is growing well, to see that the nutrition is okay, to make sure that they don't have other diseases. We check them for HIV, for syphilis, the things which we know will affect the pregnancy and we can do something about. So we are going to continuously, even now, checking and testing. Our new policy is that when a pregnant mother comes to the health facility, we shall actually give them a malaria test as well. We treat them for full dose of malaria if they do have the parasites, or we continue giving them the prevention. But the nets are supposed to be given by the district health facility. So it's not only Ministry of Health, it is partnership with the local government. You know, at the center, Ministry of Health is in charge. But at the local district, it's the local government, the COW, the district health officer, the district community supervisor, the politicians. My politicians in Busiro North should also be able to follow up what is happening in the health facilities and the health system. So they supervise government policy and government program. So that's one of the things we are doing to make sure that malaria policy are rolled out, and what we suggest that is happening actually goes and effectively help reduce the burden of malaria. But I wish to comfortably tell you that we have grossly reduced the malaria in Uganda. From the 45 million cases we would get in a year 10 years ago, we are now talking about 12 to 13 million cases of a year of malaria.
Which is still a very, very, very high rate.
It's a very high rate because, like you're saying, every Ugandan, one in every 3 Ugandans should get a malaria episode a year, because we are 45 million. So if we get about 15 million cases, that means 1 in every 3 Ugandans has gotten malaria in here. And that's an expense, and that's bad to the economy because they have to spend, they have to take away time, and that's time lost. But we're doing our effort, and we call upon everybody. We've adopted what we call the mass action against malaria. It is every person's responsibility to see that they are malaria free. One, know that you're at risk, means you have to take preventive measures. It's your life, it's your family, it's your children. The community leader must know, as a father, my home is clean, the environment is good. If I can afford, I give everybody a net. I also go and pick the government net when it's given. I make sure that when you are sick, we take you for a test and treatment given quickly.
In your discussion here, you highlight so much about the mosquito nets. But let's take a look at this campaign. How effective has it been as well? Because personally, I do not remember the last time I actually received those nets. Now, the funniest thing is that, I know you talked about people receiving them, and then it's one way or the other using them for the right purpose, because I've seen those who use them on nursery beds. Yes, they are there, but I think that's due to maybe lack of the literacy about their importance. That's aside, you could highlight on that as well. But then, effectiveness of the campaign and distribution process itself. I have seen, for example, sub-county chiefs who participate in such processes, and people at the sub-county level, and you will find that one home which has actually fewer people, but because one of the people in there knows the people distributing, they will take a lion's share. These are things I've personally witnessed. It's not that I've been told by anyone. So if such things are actually done, and that is why I'm saying that the clerks on the trucks that distribute these nets actually, I do not think are doing the right job. And that is why my worry is, you could sit there in your boardrooms and think Manafa has received about maybe 20,000 nets according to their population, when in reality about 15,000 have actually gone to fewer homesteads.
I think the current, because we've been learning, we've done this 3 times. Okay. So when you do this at a national level 3 times, there is a lot of learning. We've learned, in fact, this should be the 4th time, every 3 years distributing nets. So once we learned that people can come to a point and collect nets, this time round, because of COVID, we cannot gather the whole community to a central collection point. So now we adopted where we go with the village community leaders, the VHT and the LC. They deliver the net to you at your home. They register you. We are not using paper system. We are using data. We are using electronic forms on the tablets and on phones. We capture your information. The people we are moving with know who you are. We capture that information. It is sent back directly to the center. Then they reposition the nets. The nets this time are being distributed by National Medical Stores. You know, National Medical Stores is the one which has been giving out all the medicines in the health facilities. So they have a network to be able to reach every part of the country. And we are seeing improvement, but we are also strengthening our own health systems. That now a government will not have to depend on private providers, will not have to depend on external people to distribute the logistics of these nets. So we've now learned that we are using the National Medical Stores, we are using the local providers to move the nets to the community. Then at the community, we are using the Gombolola chiefs, the local leaders, the LCs, the VHTs, and a few people from the center to do monitoring and evaluation. Some of these nets, majority of these nets have been donated, or somebody else has funded. For instance, Against Malaria Foundation is based in the UK. It has given us almost 9 million nets. They have put somebody here to track, to make sure the net arrives at the final person. That is our accountability as government. Therefore, we are also keen to make sure our efforts are not wasted. Our effort is not to give you a net. That's not our job. We are not in the business of doing logistics and management things. Our aim and our work is a public health intervention. We want to have a healthy population. We want a malaria-free Uganda. So we also put in a lot of effort and thought and track to make sure our objective is attained. So one of the ways to attain our objective is to make sure as many people as possible receive mosquito nets. Otherwise, we shall be doing the same things, and then our efforts will go to waste, and then we shall lose steam. But our focus is where they have the highest cases. That's where we are going to put more attention, and we're going to make sure we track continuously.
Dr. Daniel, what are some of the major challenges in the fight against malaria? For example, maybe mosquito net distribution campaign and other campaigns that you've had. What's failing Ministry of Health to achieve some of its goals in the time frame set out?
Two things. I would mention two things. I'll start by the individuals before I come to the ministry. You see, in my home, I am the father. I have a mother. We have children. It's my responsibility to make sure I protect my children, not only from malaria, but all other harm. Now, this is a health harm we can prevent. There could be harm of other things, drainage, where they sleep, how they eat. So, personal responsibility and people knowing that they are at risk of malaria. Many people think malaria is a simple disease, but it kills 16 people every day. So, personal responsibility. As a ministry, I can categorically say that funding, the Abuja Declaration, where Uganda is a signatory, said 15% of the national budget will go to where? To Ministry of Health. Not Ministry of Health, but for health care. As we speak now, it is just approaching 9%. So we need to advocate with the politicians, the members of parliament, the cabinet and government, and say, please fund health the way you said you will fund it, for the money to trickle down. Now that 15% is to help the whole other disease burdens, not only malaria. And we know that there are so many, but malaria is key. HIV, TB, non-neglected diseases, accident, infrastructure, staff. But we also need to increase the funding. So the major factor and challenge we have is funding. This mosquito net is almost being funded 80% by donors, external resources, global fund, whereas we write grants, but it's somebody else's money. USAID, PMI, and many other well-wishers are putting money to help us prevent malaria. But we need government to increase the funding. So we need to, now it's not only government, we also need the population. We have goodwill, we have corporate responsibility, we have Ugandans who have enough money, and they, not enough, but have money they can help us to fight malaria. We should be reaching out to them and say, can you fund, can you give $1 per everything you sell in our country so that we can fight malaria, so that we can have a malaria fund which can continuously provide resources and not only wait for external funding.
Yeah, Dr. Daniel, they are trying to give insights on how best the fight against malaria can be improved in there. The other name you could forgive me.
Chabayinze. Chabayinze. Omulangira Chabayinze. It's a royal name from Kampala, Uganda.
It sounds a bit hard for me. But then as we come to the end of this show, what would be some of your last remarks when you look directly into that camera and then probably we could wind up the show with that if you feel there is anything we've not expounded about during this special talk show.
Dear Ugandans and people who view Record TV, my appeal to you is that preventing disease is your responsibility. We've been talking about malaria, but I want also to emphasize that COVID is in the community. And COVID also prevents with fever, and people may start testing for malaria when you already have COVID. So be responsible, wear your mask, do the hand washing, keep social distance, prevent COVID, because that is fast spreading. It's from one person to another, so that we don't lose the resources and the steam we've had. Secondly, because if the hospitals are overwhelmed with people who have COVID, people with malaria will be left on the verandas. There will be no health workers to look after them. So let's not congest our health system. The other appeal is that take care of your responsibilities in the home. Every fever should be treated quickly within 24 hours, especially for children under 5 years. They're the most vulnerable. People who have other conditions like sickle cell, who have other diseases like diabetes are also very vulnerable. Please, let's prevent malaria. Let's prevent death due to malaria. And I think Uganda, we are able to eliminate malaria deaths, even in the shortest possible time.
Well, Dr. Daniel, there telling you about malaria, and I hope you've listened to this special moment of the talk show where we've discussed issues to do with malaria, and I hope that you take the advice to stay safe, especially in this point of the COVID-19 pandemic. My name is John Jimmy Msimbi, and well, that's all we had for you this afternoon. Up next is the UG Polls show. Good afternoon.
From now on, we will all face new challenges as intense as the ones we are experiencing today. But the toughest battle is what we fight inside us. Many are discouraged and dominated by the spirit of defeat, while others already know that without the Holy Spirit, it is impossible to move on and overcome all obstacles. In the universe,